My name is Zach Ford. I'm with AIDS United Sector Transformation Program, and I want to thank you for joining us today for the 5th webinar in our monetization series. Attendees of this webinar will learn firsthand from AIDS Foundation of Chicago about their experience contracting with payers. The webinar will last approximately 1 hour and does include time for Q&A at the end. Today's slides and a recording of the webinar will be available on the AIDS United website. At AIDS United, our mission is to end the AIDS epidemic in the United States through strategic grant-making, capacity building, policy, technical assistance, and formative research. AIDS United is a national nonprofit organization with a singular mission and focus to end AIDS in the United States. We lead the charge for responsive and effective federal, state, and local policies that benefit people living with and at risk for HIV. We invest in innovative models to meet the needs of communities affected by HIV and AIDS. We have given more than $104 million in direct funding and leveraged $117 million to increase capacity of communities and organizations responding to HIV in the United States. We inform the field with best practices and lessons learned. We advance advocacy based on sound public policy, strategic grant-making to affected communities, targeted and tailored capacity building for organizations responding to the epidemic, and research and evaluation to inform the field. We work within a social justice framework that challenges the foundational issues of racism, sexism, homophobia and transphobia, socioeconomic inequality, gender discrimination, and stigma. And with that, I will turn it over to Kathy from AIDS Foundation of Chicago.
Thank you so much. Well, I am pleased to be here today to share their experiences from the AIDS Foundation of Chicago. I have spoken nationally and received input from people across the country, so it will be about what AFC did, but how it will reflect input from others I've had over time. So in getting started, how I frame it is opportunity and innovation and what HIV CBOs can be doing to get more engaged. We're going to cover at a high level costs, lines of business, billable and non-billable services in terms of what direction to go, customer value proposition, and relationship building with contracts. So you have a lot to cover. I'm going to interweave everything, and hopefully you'll come out at the end with impact and what you can do for your organization. Basically, because of new delivery payment models and new revenue generating opportunities, there's a lot that can be done for HIV prevention and care services. And there are particularly opportunities for people working in non-clinical community-based organizations. The new emphasis on population health and care coordination for people with complex conditions is kind of ripe for thinking outside the box, trying to apply what we've been doing over all these years, and helping your patients to have better outcomes, or your clients, as you might call them. However, as I think we all know, change can be hard, and we want and need to be part of the solution and to make an impact. And so that's what I'm going to go through with you today, how that can be done. The first, I have several polling questions, and I'd like to get a sense, especially since I can't see you, what type of HCBOs are here today. If you can make a selection on the poll, and I guess I'm going to defer. Sarah, are you handling this piece?
Definitely. So folks can click in the multiple choice option, and we'll read the results aloud.
And hopefully you fit into one of these categories. If not, don't worry about it.
So far we have one response. It's a CBO located in a clinic. For others on the webinar, for this and future polls, you can just click right on your screen to complete the poll. And we also have an FQHC on the line.
Okay, well, I think maybe since that's coming in slowly, we'll just hopefully
Great.
we'll catch up at the next poll.
Perfect.
Okay, so we do say, the royal we, in terms of HIV, CBOs, and the HIV community at large, face general challenges, as you know, but I want to put it in the framework that how I look at it and how we developed our programs at the AIDS Foundation. So we know that Ryan White reauthorization, the longevity of it is uncertain, although it's not going away tomorrow. It's always what will happen to it. We need to prove these days, we have to really be able to prove what we do works and be adaptable to all the changes. Measurement is more important than ever before, while we also keep pay close attention to the payer of last resort and helping our clients navigate through the health plan literacy system, because that doesn't get done in many cases unless we're the ones doing it. The new addition to this actually is Getting to Zero. There's a lot of activity in various states with PrEP and looking more closely at viral load suppression, and that takes on different meaning in trying to work with the health plan system. So HIV is going from a long history of grants to fee-for-service to capitation. And I don't know, the mix of the audience actually as far as where anyone might be, but the real big difference is going from volume more in the medical provider setting to value. And that, I'm sure you've seen that wherever you turn. There's a focus on quality and basically a fundamental funding shift as to how the whole system is working, trying to work. People are trying all sorts of different models. And I think there's no one right answer yet, but we need to keep moving along and it being adaptable. So during this transformation of delivery is really about delivery and payment reform. So how and where the medical services are delivered, how they're paid for, outside of the typical grant situation that we're most used to. Our skill set and credentialing and measurements are all part of the new language, as well as communications and public health information, private health information applied in new settings takes on new meaning, has been our experience. So why do this? Why change? One, we need to join the journey. The journey is happening. The train has left, as to use phrases, and we need to be part of it. It's an opportunity, though. We can serve many or some of the same clients we've been serving if they've moved over into Medicaid insurance or other types of health plans that might be in your state, that they're no longer in the Ryan White, maybe for case management or other services. Maybe some parts of Ryan White applies, that they're eligible for. It's an opportunity to expand and apply your experience and expertise to more people. We always have limited funding. We can serve X number of people with the funding we get from HRSA, however we get that money, whether direct or through the state or city governments. And so there's way more people out there in need of our services, and this is a way to do it. And it also at the same time diversifies their funding sources and allows our organizations to grow, be adaptable, and sustainable. So that's the opportunity that I think we all need to look at for growth and to serve more people and have better health outcomes, of which is essentially the essence of the triple aim. Hopefully you're familiar with it. These days it's getting a little bit updated to the quadruple aim, but basically even if some of these words that are on the screen are not spelled out in grant applications, RFPs, proposals, it's pretty much in everything we see. And it's not a bad thing. It's just how do you do it? And even though people talk about it and that we're supposed to have this goal of the meet the triple aim, I will tell you that no one really has figured it out. But everyone's making attempts at it, and there's pieces. And since it's a three-dimensional model, it's just sort of like shape-shifting in terms of adapting to the changes that are out there. But bottom line, we need to look at quality of care and need to measure it. Cost-effective care, need to measure it, because how else will anyone know? It's just kind of like If it didn't document it, it didn't happen. And we need to also be able to measure health outcomes. Not so simple. So what that does is position everyone who takes this approach that you do need to be prepared for increased amounts of financial risk. And going across on the arrow, those are just different ways, methods of payment, and you'll see increasing to the right, increasing provider financial risk as you change the reimbursement structure as it's labeled. And it comes down to how much risk are you willing to take. Now, that if you've not experienced it, you might say, what kind of risk? And it's you and what it means, at least, well, it would mean this to other states besides Illinois, but if you have a contract for a certain type of payment structure, like pay for performance, and if you don't perform as to whatever the terms are you've agreed in your contract, there'll be a withhold from what they pay you, or you won't get your contract renewed. There's just different things, and I don't mean to be negative, because I think if you approach it, as we'll talk about later, as a partnership, every effort will be made to succeed. But there is an element of risk anytime you talk about money. Now, in terms of taking a look at business development opportunities, and that's my role really at the AIDS Foundation, is to do strategy and business development, is to look at ways in which you can develop your business. And so I'll use business. I refer to things as business. Working outside of the grant world, and even your own agencies are a business. You can extend your service line. You can have for your current services, you might have new people who pay for it, or new markets that you serve. Or you could have new services that you choose to provide for your current customers, or new markets, or strategic alliances. And so what does this really mean, besides sounding like mumbo jumbo potentially, is you could add behavioral health services, you might add medication-assisted treatment, workforce development, trauma-informed care, serve veterans for new markets. It just all depends on who you are and what you do, but there's a lot of options out there that are worth exploring. So in terms of strategic readiness, to achieve this high-quality, cost-effective care while you're diversifying revenue, the triple aim, there's a checklist that everyone needs to do, and we did it, before you have your first conversation or your first serious conversation with the managed care or health plan. You do need to know your costs, what's your capacity in terms of your workforce internally, or what you can tap into externally. You need to look, and we'll talk some of this, to find your competitive advantages. You need to know your market and define it for each managed care organization. They all serve a little different. No two MCOs are alike. Just like in many ways, no two FQHCs are alike, because you all emphasize different things. You're in different markets geographically and otherwise. And then you need to understand the requirements and standards of each MCO. And they're not the same. They really vary. Why they vary so much is kind of beyond me, but a lot of them that might be in your state are owned 2 ladders up the chain. Like Harmony in Illinois is owned by, well, actually they just merged with Meridian, but they're really WellCare in other parts of the country. These companies are so big that they all have different standards. So you need to know all this to build your business case. So that's what we're going to. So first we're going to talk about costs. So another polling question, and hopefully we can get a little more respondents now. Just mark on your screen, if you've calculated the unit costs for each service you could potentially market to health plans. And if you haven't and you don't know what I'm talking about, that's okay too. Just helps me guide the conversation. So if you could take a quick moment and indicate where you're at.
So this is Sarah again. We see we've got one person who's taken the poll so far. They're saying yes, they're working on it. And once you take the poll on your computer, you'll see the results. I'll go ahead and skip to the results once we've gotten a few more answers in here. We've got someone else saying they're not sure where to start. And another person saying that as well. I'm going to go ahead and show the results here.
Okay. Well, then hopefully you'll get more information on how to start today. Thank you very much. So now we're going to talk a quick high-level view on costs and pricing. A lot of people do costs different ways, and you may have been on other webinars that where you take this many people and this portion of their salary might go to this service, and then they might spend this much time traveling, and then they add it all up. I really believe the way to go is unit cost. And the reason why I say that is, for the most part, and this is not universally true, but for the most part, health plans in particular pay you or will pay you on a per member per month basis. And that per member per month is a unit of service. And so that's why when you're negotiating, and we get a little further down the line in these slides and talk about that, that if you know your unit cost, looking at your costs at the unit level will really be helpful. Now I know I have a question here to the audience. I usually ask this question when I can see the audience. But I left it here intentionally, so if you could just think about it, why it's important as we step through the slides. So we need to consider all the resources that go into doing unit cost analysis. So the first step, and the steps are laid out here, and we'll go into more detail on some of them, is to identify the service whose costs you want to know. The next step, and this is what I find particularly helpful, is a bottom-up, what I call bottom-up approach. You start by determining individual costs associated with a unit of service, and then you're going to add them together when we get down the line, and it should come together for you. But knowing the costs of your services can help you with setting fees, planning for the future, and negotiating better rates with health plans. So that is why it's so key, because if they offer you if you're with someone, actually any setting for that matter, and they offer you a contract for X amount of dollars, how do you know it's a good price? How do you know that price isn't above, they're going to pay you less than your costs, or break even or more? So depending on your agency's goals, hopefully it's not to lose money, because there's no reason to lose money, especially after we just saw that Blue Cross Blue Shield took in record profits. There's no reason to lose money. So we look at the time period so that you have that in your math, and we calculate the direct costs and the process map. I'm going to walk you through a process map. But the other thing that's an unknown, it varies, is the indirect costs. Now I know if you're used to getting Ryan White funding, you have a cap on costs. Everyone always says, and probably rightly so, that 10% is not enough. But what is it really? You can get an approved cost from the federal government, but you may find that if you add your indirect costs into your direct costs for negotiating or talking to another type of payer, that you become too expensive for them. And that's just something you kind of learn over time, figure out what they're willing to pay. But it's really something that depends on your agency's fiscal policies and procedures. And some agencies, even though they have indirect costs, and it's a real cost, covering phone space, computers, etc., they may allow you to not have to include that in your negotiation with a third-party payer, where you must include it for a grant. Somewhere someone's got to get it covered, pay for it, but perhaps not here, and that would be great. So walking the process. I don't know, and this is hard when I can't see you all, but for your familiarity with a process map. It's not commonly used in our settings. It's very common in other sectors. So I'm going to use the example of making coffee because most people could relate to coffee. And it's really a step-by-step process where you have to, but this is to apply to your services that you offer, breaking it into very granular pieces. We're going to be looking at the travel time. Of course, not really travel time for coffee, but travel time, the percent of time it takes you to do the service, the amount of time, number of people involved. Like for a service you might do out in the field, maybe you send 2 people for safety reasons instead of 1, and that's a cost because you've got 2 people out there. So it's a visual way of looking at problem solving, showing the processes, and lets you figure out, this goes into figuring out the price, unit cost, I'm sorry. And there is a website that I've listed there that can help explain more. But people do tend to get stuck here, and I can understand why. But once you get used to the process map, you'll just love it. But in the end, it's about balancing. So we've got costs at the top, which we talked about. Price on the left side is what you're charging someone, getting paid, and the difference is the margin or your profit. You are allowed to have this margin as a nonprofit, and that goes into different fiscal rules, but it does not, in and of itself, does not jeopardize your 501c3 to have margin. You do not have to break even or be at a loss to do this kind of work. So lines of business, that's the next big piece for doing this. Line of business, as it says here, is a set of related products or services to meet a customer's needs. And we're going to talk more in depth on this. And related to what you're doing for Ryan White is you take the Ryan White services or whatever other kinds of services you have. You may be already doing behavioral health services or something. You take the services, you break it down into what is it funded to do, and then you will have multiple programs, or you have multiple funding streams, or you can do 3 things with the pot of money that you get. But you want to translate what you're doing now into a marketable product to third-party payers so you can continue to serve some of your current or former clients as well as new. And this draws on your expertise. So for example, if you're funded for case management is a bundle of many services. So to go a little deeper on this, actually I'm going to go ahead 1 slide, and I'll come back to the other one. I really kind of viewed it like pulling teeth. I went around at AIDS Foundation to all our program people, all who got funded for various things, and it's like, tell me about what you do. Well, we're funded for prevention, or we're funded for case management. Well, what in case management? Then drill down. You just keep drilling down, and after you're able to, I got actually 9 lines of business out of what the AIDS Foundation was thought of as we do prevention and care, and not counting our advocacy, but for services. And so there's a lot sitting there. It's just because of the way we've been paid is really different than the way the rest of the world looks at what we do. So we described our services. We looked at the units of service because that's where we did the unit pricing. We had to look at the volume. How many people do you do this to? You want to be cognizant of evidence-based interventions. So if you're doing motivational interviewing, or you're doing a screening that goes into it, that takes time, and there's training that went into that. You're looking at the workforce that you have and the expected outcomes. So it draws on all of these things as well. That's the line of business. Then you have to market it, then you get contracts, and then you have experience. And it is so not that simple, but it does boil down to that. The steps then are you're going to inventory your current services, look at which ones can be freestanding that you can isolate and package. Then you want to do an external scan to the outside world around you to see what gaps you can fill. Like, for example, if you're doing a behavioral health service for mental health, let's say, for people with SMI, serious mental illness, and there's 10 other agencies doing it and working with health plans already, that might not be the place for you to start because you have to break in. So you want to see, it's just like what we do for gap analysis. You want to identify any weak spots, strengthen them, and then list the features and benefits for each line of business that you have. So what now? Where does this take us? We've talked about costs. We've talked about lines of business. But which way do we go? You're at a fork in the road, basically. Depending on the kind of organization you are and the kind of services you're delivering, you can go one of two ways to get paid for what you're doing. You can become the service itself could be billable. And what does that mean? It means that Medicaid, I'm going to use Medicaid, will pay you for it because there's a code associated with a billing code. And I'm not going to go into detail on that. Lots of webinars out there on that. But you go into the billing, you can use the billing code and get certified and credential your providers and go that route and bill. You could be doing that now if you're eligible. Whoever was the FQHC, I'm sure you're doing that right now in some aspect. But for the non-billable services, it's very different, and I would highly recommend it as a way to start. Again, it's a little bit state dependent, but not that much. There's room here to do this. The Affordable Care Act requires health insurances to submit data on their MLR, or medical loss ratio, as you might be familiar with. And the ACA, that was another plus of the ACA, in that it had to be at least 80 to 85% of their expenditures, of the claim their revenue, had to be put towards medical services. It was lower than that before. And why is that a good thing? Because the difference between, let's say, 80% and 100%, 20%, is for them. It's administrative costs that they can use on admin costs, marketing, and profit. But it is also where they can pay you. And that's a great direction to go. Basically, you're focus on the non-billable. That's what I'm going to do. And how you do that, I mean, I'm sure you've heard, and some of you might have electronic health records and claims that what a pain, and we have to go through billing, and what if all of that. This is a different route. This is so not that route. This is a direct invoice. And this works for non-billable services because you're billing the health plan or entity that you're working with directly. And they pay too. So the word options is actually not quite right here. It's more like alternatives to medical billing. I apologize for the wrong word. But you can do pilot or demonstration projects with, I'm going to just say, health plans on services, savings, value-based services. They're trying things out too. Why not partner with you, and you all get to know each other, benefit on behalf of the patient. Non-medical services, direct partnerships. Some of them view it as partnerships. Some of them just view it as business. It is all business, but if it's a true partnership, depending on the climate in your state, the governor in your state, who runs the MCO, it can be a true partnership spirit. We've had that. It's really nice. And hospital and health systems, not just health plans. I wouldn't overlook, now that health systems are looking at population health and community health, and they're actually waking up to social determinants of health. There's a lot of opportunities there, and we're in conversations on a number of levels on this. So the next big chunk is customer value proposition. And I don't know if you're familiar with it or not, and I find that a lot of people have different understandings of it. So this, oops, hang on, I just lost my, sorry, my screen just went dark, just a minute. Customer value proposition is really the distilled essence of what your organization's mission and strategy is, what you bring to the table. And why do you need it? It shows you're credible. It's how you differentiate yourself between, depending on where you're located, you may or may not have direct competition for what you're trying to do. But it's the thinking of what separates your business from your competitors. So there's three main points when you think about customer value prop. Sometimes it's called value prop. It's not exactly the same as value add, but it's close. But it's actually a statement. Value add might be just, well, we've been here for 35 years or whatever the case may be. But it's actually a whole, it's a little bit more embellished than your elevator speech. And it needs to cover who are your target customers, why they should buy from you, and what you're delivering. But the main thing to know is you need to kind of cut through the clutter of people. If people are competing, and it is a competition out there, you may need a value proposition. You wouldn't say our value proposition is this, but it'll come through in your materials, your speaking, and you need to know your customer, know your competitors, and know the service that you're delivering. And I should say know what the MCO or the health plan is actually looking for. And that's sort of hard to figure out, but through conversations with others or the marketplace or going to state-run Medicaid committees, you can chip away at that. The value add is, in essence, again, the enhancement a company gives its product or service before offering it to others. So sometimes what happens is so what a customer value proposition is not, it is not your services. It is not just listing benefits and features. It's not your mission. It's not your tagline. And it's not a headline. But in essence, I would say it would be what people are calling these days your secret sauce and how that differentiates you. So, but you need to be prepared to answer, what do you bring to the table that others don't? So how do you create this? Because it probably sounds like a bunch of words. But we covered a lot of these points, but what I wanted to do was give you a tool. And there's many tools out there. There's many templates, I should say. And most of them aren't great. And how would you know good from not good? It's just, you'll figure that out right away. It's hard to work with. I picked this one, and I've shared it with a number of our service providers. It's clean, it's simple. It helps feed into what the final statement is on the right. But it forces you to think about all of the things listed down the left or the middle of the page, and that will help you get to a customer value proposition. And that's a whole conversation by itself. So I apologize for going over that kind of quickly, but hopefully you're familiar with it, and there are tools there to help you along with it out there. This is really a readiness assessment. The top 5 are what are very key to be able to. Right now we're still not quite ready to have our meetings with the MCOs or health plans, but you need to have looked at, and this is what we did as well, but it's kind of standard marketing. We look at what we could do staffing-wise, data, IT, financing. There's those costs again, evaluation, outcomes, ROI. This is where it really comes into play. And then the other items listed. You don't need tombs of information, binders and binders, but it's really taking a look. It's really your business plan or business plan essentially. So here's our last poll, and I just want to get a sense of how it's going for you with managed care health plans in terms of where you're at before we go through the next piece. So if you could take a moment to mark that.
Thanks, Kathy. So folks, to answer the poll, you can go ahead and click the answer on your screen. I see we've already got some responses so far. Folks are thinking about what to do, and someone else hasn't done too much. Let's see if we can get a few more responses before I close the poll. And no changes needed. Let me close the poll to show everyone the results here. Back to you.
Okay, hang on just 1 second. Oh, no. Well, I guess it's hard to ask. Okay, well, thank you, and we'll keep moving forward. So it really gets down to being part of a strategic process. And this is, we're going to just check in for a moment on what we've covered so far. We've talked about, we talked about some of it, assessing the funding landscape. You know, where's Medicaid at these days? If you're in a Medicaid expansion state or not, if you have a new governor or not, if you have new news day to day from at the federal level from the president, what he's going to do or not do with Medicaid. All of this is kind of, changes the landscape. In Illinois, at the time, a couple of years back, we were able to look at HIV-specific claims data to get a sense of trying to build out some HIV lines of business. Develop the lines of business, the value proposition, the cost, pricing strategies. Once you have the cost, then you have to figure out how to price it. We didn't really talk about that. And then prepare material for your proposals. They will want to see a proposal. It's not like a grant proposal, but it's a business proposal, and the rates and the volumes and what you've talked about with them in terms of outcomes, expected outcomes, is all part of that proposal. At AFC, for the program that I developed, Community Links, after we cataloged our services, we built the business case. We have a logo, we have a web page, dedicated phone line, and then we reached out to health plans to build our relationships. And we had a proposal in hand initially. Once they got to know us, we could just skip to the bottom line, how much, what's the scope of work, and it became a lot simpler. So in having your meetings with MCOs, you're now ready. And you want to ask for meetings with the executives and program staff. Do not start with the contract staff. A lot of people do, I've heard. And you're just going to get stuck, because especially if your expectation is to be paid through the administrative funds, where they're basically paying you out of their profits. But they have a reason why they're willing to do that, because they're being held accountable by somebody else. And that starting with contracts, they're just used to doing things like certifying providers, billing the state for Medicaid, and that's just not the starting place. You want to get to know the program staff. They can be your champions internal when you get to the contract phase. So we presented who we are and what we do. We made the ask, and we had HIV metrics, what was available at the time. It is hard to get it if you don't have access to claims data. And then we identified whatever were the next steps, and then it took continuous follow-up. And just realizing that, their priorities are not the same as our priorities in terms of what they need to get done. We thought about, always were cognizant of how we could braid services with Ryan White, but that was very difficult, and of course we kept payer of last resort in mind. And we did offer, developed a line of business that was essentially HIV care coordination, and we used the measures, and HRSA had metrics. We looked at data, viral load suppression. It was hard to get stuff that was hard to get information at the time, although it still is. Some states have figured it out. To get actual laboratory data, it depends what you've set up in your state between the health plans and your Medicaid department and your providers, like what they'll share with you. The challenges, it's okay to have challenges, you just need to be prepared for them. They do talk a different language. Got to do a lot of translating back and forth. Case management that we might call for Ryan White is they call it care coordination or care management, and there's a lot of different names. What we call locate. There's a lot, and so you just need to learn their lingo, but just assume they don't know our lingo. So when we talk about housing navigators or if we're talking about case management, they have different ideas in mind. And you just need to spell it out or ask them what they think of it and just get clarity. They're not trying to be difficult. They just, have a different level, different framework of knowledge. Database systems are a challenge. How they transmit data, what they transmit, how you receive it, how you keep it secured. HIPAA, really security is a huge issue. Not all of our community partners could even send a secured fax at the time. So that is key. Staffing capacity, what you can do, what you might subcontract out with, is all very important when you're having these conversations. And then it usually becomes, and it's still to this day, because I meet with them and I have contracts now, is a hurry up and wait scenario. They want to meet, hurry up, and then, they take forever. Our average contracts take a year to get. We have a revolving door of executive MCO staff, so I submit a proposal, wonder where it went, check on it, and they left. And sometimes they show up at the next plan, or sometimes they just go to a different state. So it's staying on top of it. Not all plans are comfortable or have experience in contracting with the community. To this day, it depends on the approach from the governor. We had a governor when we started, when the ACA kicked in, that was supportive and pushed Medicaid to work with community organizations as partners. Then we had a change in political affiliation of our governor, and then all that stopped. And now we're back where we were, and so it's looking brighter. So it just all depends. But the community, so they limit it. And if you can partner and go in with a group of have your own network, doesn't have to be formal. But then they can only how they view it is only working with one person in the community instead of 5 different people. They really like that. And then there's the concept of delegation versus co-manage. It's the paperwork hoops that they have to jump through in delegation. They think if you're going to talk to them about if you're going to talk to them about doing a specific service that delegation means they give authority over to you for all the regulatory hoops. You don't particularly want that. They don't like to give it up because ultimately they do have some responsibility, but it's the lingo that you need to get comfortable. And when they use the word, what do they mean? So there's hoops, and you just have to be tenacious, patient, and flexible to tackle the barriers. It's definitely worth it. The basic steps then for a contract are, as I have listed here, these health plans, basically I play lawyer to some extent, but I only go so far, and then I do have legal review on the contracts, but working out the scope of work, being as clear as possible. Most of the time they don't know what they want. And they don't know how many people, they hem and haw, but that affects your price and how you can scale your service. So just trying to be as clear as possible. I suggest starting small, having a manageable number of members, because it is if it is new for you as a payment and delivery model, you want to make sure that you can manage unexpected changes, and you should expect the unexpected. So as simple as we had an HIV contract and we got a member sent to us for the month to do our HIV kind of care coordination service, and we go knock on the doors, contact people, and they weren't HIV positive because they coded it all wrong. So that was a tough one, but you just need to be able to adjust, deal with it. So that's why, starting small is really a great idea. So as a resource sampler for you, I generally think things fall, for this topic in particular, falls into two categories: reports and tools. You may be familiar with some of these sites before, but maybe not looked at these specific topics. But I wanted to provide something. In terms of action and what you can do now, this is a recap of much of what we talked about, but looking at needs, looking at understanding the external scan, your level of risk, how ready are you. You may need to have funds identified for TA or coaching, depending on your structure and where you're at, and help with starting steps. Maybe you don't. And then there's collaborative options for network formation as listed here. And this kind of gets at having payors, these new payers, having fewer people to have to deal with. You're both trying to serve the member or who might have been your client. They're coming at it by and large from a fiscal perspective, and you're coming at it from a mission perspective. But in the end, you just want to have better health outcomes for the people you're serving. So that's just how it is. But because of their motivation, that's how you can be able to do new things. So as MCOs and health plans increasingly favor payment and partnership models that shift more of the risk to providers, as I mentioned, you just need to be ready and to be part of their solution, the solution, and to make an impact. And with that, takes us to questions.
Thanks so much, Kathy. That was really a wealth of information. So for folks on the line, this is in listen-only mode, and you can put your questions in the Q&A chat function on the bottom left, and we'll go ahead and we'll read them out to Kathy. We've got one question about if the slides are going to be available. Yes, they will be. They're going to be available at aidsunited.org/webinars, along with the recording of all this wonderful information. You'll get an email if you've been registered for this webinar when that is live, and you can always send that out to your colleagues for them to access this as well. Kathy, while we're waiting for other questions to come in, is there anything that you would like to expand upon?
No, I guess I'd really like to hear, I could have talked about any one of the topics for a whole hour, but I was trying to really go across, costs and lines of the whole, to paint it as a fuller picture. But if something wasn't clear or you wished I could have spent more time on, that would be helpful to know.
Sure. So folks, you can let Kathy know in the chat box what topics you would like to learn more about, or if you have additional clarifying questions. And we'll just pause for a moment as those come in.
Hey, Kathy, this is Joel Menges. I just wanted, while questions are hopefully coming in, was there any specific software that you recommend or use to help people track their time, or to help you administer the billing to the plans for the services you did under contract or do under contract with them? Or did you sort of do a homegrown, or how did you just handle the tracking, of the new kinds of things you're doing in the billing for it?
Very good question, and I should have touched on that. We have had, and we're in the process of switching, but we have had for our Ryan White services and our housing services been using Client Track. So that, and our state and city health departments require us to use Provide. I don't know how many other people might be using that. So we had to amend. It's basically a database system that has a lot of fields and modules, and I worked with our data department to make sure that what was transmitted as outbound from the health plans could be received by us as inbound data. So we did have a consultant who looked at Client Track at the time to be sure that it could be modified to meet the needs that we were expecting to get from the health plans, the way they export their data on patients' claims data, visits, codes, and all of that. And so we did use that system. And in getting a new system, for reasons having nothing to do with the health plan, I made sure that it can do the same thing and still receive the data. So it did do that. So when we get it, they send us a monthly membership list to do whatever it is we've contracted for. It goes into our database and then gets processed by, we have a community links operations staff now because the business grew, and so we were able to do it that way. On the billing, because it's an invoice, we just had our finance department, our operations person said, this month, this PO, so many people times X dollars, and they invoice the plan as agreed to in the contract. That was straight up invoicing.
Thanks so much, Kathy. We do have a question in the queue. We're curious, what surprised you most as you delved into this world?
Well, that's a good one. That they kind of knew less about how, I thought it was a little scary actually. They kind of knew less how to serve their patients, their members, because they're members, and there's a distance inherent in that from clients you serve. I was surprised that they weren't as well-rounded on disease states. They don't need to be, but I guess it was disappointing that because we do trainings for them on HIV, and I mean everybody needs to be trained. So that's okay. I guess I'd have to say the data aspect, that I think we all thought, oh, big insurance company, they're nationally even, and what they do and don't know about their data, how they can pull their data, the fields they use. It wasn't as sophisticated as I expected, and that really was a surprise.
That's really interesting. We have another question in queue. What advice would you give to someone who is thinking about pursuing this, but their leadership is concerned that it's too much work?
So I would answer that coming from, I don't see how you can't do it. Because we don't really know. Now I'm the person who pushes change here, so that's the first you got to understand that. But I think people, you need a seat at the table. As I started out, it's because the table keeps changing, and as we don't know what Medicaid, getting to zero, what's that going to do for how people serve people with HIV? I mean, there's still, and I say getting to zero, not the zero part, but the getting there part, in terms of needing increased PrEP utilization and lowering viral suppression rates. So that's a different world for them. In order to be successful, They need to understand this world. For them to understand this world, you need a relationship with them. If you first have a relationship with them by providing a service that they need and that you can diversify your revenue and serve more people, I don't really see how you can go wrong. And but I say that, you just know there's not a lot of people doing what we're doing from the administrative part. Now, people bill, the FQHCs, you're used to billing through the traditional route, but I think it comes from, in terms of leadership, I don't know, it's like, what is the strategy for developing new business? It's got to be that approach. And there was that understanding here that we needed to be part of it, even though we didn't know what the it was going to fully look like. And it's that. And it may not be there. I mean, I don't mean to be discouraging at all. This is, I think, critical, but it's worth another couple of tries to get them to think about it differently. I hope that's helpful.
Yeah, thank you so much, Kathy. So that is the end of our questions in the queue. So I'm going to turn it over to Zach to close out.
Thank you, Sarah, and thank you, Kathy, for such a wonderful webinar. I really appreciated the thoroughness that you went through that. That was excellent. I just want to let folks know that our last webinar in this series is going to be on April 11th at 3 p.m. Eastern Time. This is going to be focused on collaborative learning and really kind of wrapping up what we've done in this series. I don't know if Mo or Joel wants to add anything about what we could expect from this webinar. If you haven't developed the content yet, that's all right as well.
Yeah, we will. You're right, Zach. We haven't put the slides together yet, but we are. Yeah, it will be sort of a synthesis summary of all the puzzle pieces that we've had, and also just wanted to reiterate thanks to Kathy. Yeah, this is tremendous to get the true inside the tent perspective.
You're welcome.
Great. Well, just one final reminder that slides from today's webinar, along with the recording, will be available on Age United's website, and those that were in attendance or that were registered for the webinar will receive an email notifying them when that goes up. Thank you so much, everyone, for participating in today's webinars, those that asked questions, those that joined us, and of course, thank you, Kathy, for presenting today. And this concludes our presentation.